The hemolytic anemias, the big ones are going to be hereditary spherocytosis and elliptocytosis. These are both autosomal dominant. So again, remember modes of inheritance. What happens with both of these is that the red blood cell has an abnormal shape and it does not bend and fold as easily as it goes through the capillaries, and it gets deformed, and then it gets trapped in the spleen or hemolyzes a lot easier. So it's because of strange shape to the red blood cell. These patients can present with anemia and hyperbilirubinemia in the newborn period. Usually it takes a little bit longer for them to appear. They can also have hypersplenism because these cells are being trapped in the spleen. They are also will be more susceptible to aplastic crises, and those are usually triggered by certain viruses. Also, patients can develop gallstones because of the increased bilirubin from the hemolysis. These patients will have an increased reticulocyte count because the problem is not in the bone marrow, the problem is out in the circulation. The cells are being destroyed, the bone marrow receives a signal and produces more cells, so the reticulocyte count will be elevated. They can have an increased bilirubin simply because of all the hemolysis that's going on. The liver simply can't handle it, and so you will see jaundice. And the important thing is the peripheral smear. You will see the strange shapes of the cells. There will be either spherocytes or elliptocytes, depending on which disease you have. And especially for spherocytosis, remember the osmotic fragility test. And this is for diagnosis of spherocytosis. The treatment is going to be transfusions to keep the hemoglobin up. Again, you worry about iron overload, and if you're giving too many transfusions and you worry about iron overload, they may need to go on deferoxamine. You try to transfuse them as little as possible, and you try to hold off splenectomy for as long as possible. But removing the spleen is very helpful because now those cells are not being trapped in the spleen and being destroyed. Unfortunately, once you remove the spleen, you're at higher risk for certain infections. So you can see how a question might run. They might talk about a patient that has hereditary spherocytosis. They may mention that it needs a splenectomy, and they might actually ask you about what immunizations the patient may need prior to splenectomy, or they may ask you what organisms the patient is at risk for infections, and a variety of questions just from that one concept. Here we see very round. Remember that typically the red blood cell is biconcave. This is a very round spherocyte, typical on the peripheral smear. These are the elliptocytes, and you can see they have a different shape from the spherocyte, but are also an abnormal shape, and they get trapped also and deformed as they go through the capillaries. Enzyme defects can also cause hemolytic anemias, and we talk about pyruvate kinase and glucose 6-phosphate dehydrogenase. Pyruvate kinase presents in a variety of ways, but the patients will be pale from their anemia. They will have jaundice because of all the hemolysis, and they can have splenomegaly. Again, the reticulocyte count will be elevated because this is a problem that's occurring in the circulation, not in the bone marrow. The bone marrow tries to compensate by producing more red blood cells. Unfortunately, they're also defective. The diagnosis is made on pyruvate kinase assay. That's the test to order. And the treatment is, again, basically supportive. You do transfusions and eventually splenectomy so that you can not have them all trapped in there. G6PD deficiency is X-linked, but also remember location. You have to know geography to do some of these questions. So look for patients that come from Asia or Mediterranean descent, and also look for a patient that has some kind of trigger. Usually patients do fine until they're given something or they're exposed to something, which then triggers the hemolysis. Look for a patient that has received, eats fava beans. That's one of the classics. Also, certain medications can trigger G6PD and cause the hemolysis. Look for an acute drop in the hemoglobin because they start hemolyzing very quickly. You can see Heinz bodies on the peripheral smear. They will have reticulocytosis, again because it's a problem in the circulation, not in the bone marrow. The diagnosis of G6PD deficiency can also be made with a direct measurement of activity of G6PD. Treatment is basically supportive, and certainly you need to avoid any of the triggers. So fava beans, you need to avoid certain medications, the antimalarials, for example. Sulfa drugs can trigger G6PD, and naphthalene. I remember taking care of a baby once that was about 18, 24 months old, came in with a hemoglobin of about 4, and further history revealed that the older sister had been playing doctor with her and had given her a mothball as a pill to eat while they were pretending to be doctor. She took the pill and she started to hemolyze, and she dropped her hemoglobin very quickly. So avoiding any of those triggers will help. They may need transfusions as needed. This is the Heinz bodies that you can see in the smear. The arrows point to them here, and all these little areas here. Those are cells with the Heinz bodies that are seen with G6PD.